Hello, my name is John Davis. I am professor of medicine at Mayo Clinic in Rochester, Minnesota, and an associate editor for the Journal of Rheumatology. I would like to welcome my colleagues with Dr. Dafne Capelusnik, Professor Annelies Boonen, and Dr. Sofia Ramiro to talk today about their article published in the May 2025 edition of the Journal of Rheumatology titled Unacceptable Work State in Rheumatoid Arthritis, Establishment of Thresholds for Presenteeism in Clinical Measurement Instruments. So I think this is a really important article and, work on trying to understand how to enhance presenteeism at work and ability to patients to maintain their workability for rheumatoid arthritis and really all autoimmune and inflammatory rheumatic diseases is very important and a patient-centered outcome for us to be addressing. So I'm really excited to hear about this ongoing work and looking forward to learning from you all today. Let's go ahead and get started with the first question. Um, Please talk about the concept of unacceptable work state that you highlight in your article, and please kind of give us the background and rationale for conducting this research.
Sure. So rheumatologists might be familiar with the concept of patient acceptable symptom state. So we use this term to describe and to define a patient acceptable or unacceptable work state. This is a key concept to assess patient satisfaction or unsatisfaction with their work performance or work productivity. We think that assessing this is crucial as improving their work performance or their work productivity may help us to prevent prolonged sick leave and potentially also permanent work disability. This has long-term benefits, not only for patients' physical and mental health, but also for their economic stability and also for the society. So this is very important in clinical practice, but we also believe that may be relevant in clinical research, for example, as we may identify some patients, those patients, or for example, for interventional studies, we may want to identify the percentage of patients that start with an acceptable work state and then move for an acceptable work state or vice versa. With this in mind, the rationale of our study was to define some thresholds of meaning for some presenteeism questionnaires to help us to identify those patients that may need some additional effort. And although these categorical variables have slightly lower precision, they offer a more practical and more interpretable approach, making them more applicable in clinical practice.
Yeah, that's very interesting. And I've always been, gravitated to the notion of kind of what is patient acceptable, and it's a very useful term in clinical practice. So I appreciate, the approach that you're taking here. Tell me about the specific objectives for this study and, how these kind of get at the important construct that you just talked about studying.
I'm going to take this question. We had three goals. First, we wanted to identify the thresholds at which patients feel their current work state is unacceptable. And we did that for 4 commonly used presenteeism instruments, but also for a numeric rating scale on pain, because if that would work, then we would not need the presenteeism issues. Secondly, we wanted to know whether these thresholds also predict future adverse work outcome, which we defined as short or long-term sick leave or withdrawal from work, so that it has also a predictive value of these outcomes that are really harmful for patients. You don't want patients to become work disabled. And finally, we wanted to know whether the thresholds that we developed for rheumatoid arthritis, that they would be also confirmed for the thresholds that we had already been developing for axial spondyloarthritis, because it's much easier when you can use the same threshold for different instruments. And that were our 3 objectives.
Wonderful. That's very helpful. And I think, the ability to apply this also beyond, rheumatoid arthritis to other fields, including axial spondyloarthritis, that seems like, it makes a lot of sense. And difficult to learn thresholds for every different disease. So when they can harmonize, it would sure make practice a lot easier. So I think that was a really important part of your approach. If we could, kind of get into the nitty-gritty of this now, that would be really helpful. So, trying to understand this and define thresholds. So I would like you to talk more about the resource that you used. And so I know this is came out of the Patient-Reported Outcomes Survey of Employment in Rheumatoid Arthritis, or named the RA PROS study, and talk a bit more about the specific instruments that you used and the approach to defining the thresholds for unacceptable work state.
Yes, thank you. We developed this 1-year prospective observational survey together with collaborators, and we were able to collect data in 4 countries: United States, Canada, United Kingdom, and the Netherlands. And we had, first of all, to identify the presenteeism instruments in which we would be interested. And we have chosen 4 presenteeism instruments, and 2 are easy to use patient globals. So on a 0 to 10 numeric rating scale, the first was the item of the WPAY, which is very often used and asks about the disease-related impact on your productivity. And the second global was the Q&Q, which asks patients to score their quality and quantity of work while they are at their work in the last day. 2 other instruments were multidimensional. They ask specific questions to the patients on whether they have limitations related to the output or the time pressure or the physical load or the interaction with their colleagues. And it were the WALS and the WLQ. Also, both of these are often used in trials and in observational studies. So that were our presenteeism instruments. But then we also had to select the external anchors that would help us to discriminate between patients with acceptable and unacceptable work states. And there we used 2 approaches. One was that patient acceptable work state, where patients indicate on a yes or no answer possibility, whether they feel that if the disease would stay like this for the next couple of months, they would find their work status acceptable. And the other one was the one that would help us to predict the more adverse work outcome, and that was the sick leave or withdrawal from work that we observed in the 1-year prospective follow-up of these patients. So then we had the presenteeism instruments, we had the anchors, and to select the thresholds, we used different methods. First, the 75th percentile curve of those satisfied with their work, and also 3 receiver operator curve characteristics methods, the Liu method and the Uden index and the closest 0 to 1 method of the ROC. And when we have done that for all the instruments, then we scrutinized the results, but we decided to prefer to prioritize in our selection of the best threshold to prioritize the sensitivity and the positive likelihood ratio, because we would rather err on selecting more patients with unacceptable presenteeism, because it's not harmful and it's not expensive and it's not very time consuming to guide patients to keep in sustainable work. But finally, we also checked whether the proportion of patients so correctly classified and the balance between the over and underestimation. And that was actually because the adverse work outcome was not so frequent. So you risk to have a really high overestimation. So we balanced that a little bit to make it also more applicable when thinking about clinical practice. And that's how we derived the final the thresholds that you find in table 2 for the current work state and in table 3 for the future work state.
Yeah, that's a very useful description of the methods and approach. And I really like the way you try to, maximize sensitivity and using the likelihood ratios not to miss any patients who may have emerging concerns in their ability to kind of manage at work. And I think that makes a lot of clinical sense to clinicians in the audience. I think maybe now getting to tell us about the types of patients that were studied in this project. Obviously, patients with rheumatoid arthritis, but help the audience kind of understand how this may apply to their patients in their practice.
So the audience, the study population we included were 104 patients with diagnosis of rheumatoid arthritis, according to the rheumatologist. They were all at the baseline, at least, had some paid employment. 77% of the patients were female, with a median age of 48 and a mean disease duration of 10 years. And from all the employed patients, 20% of them had blue-collar job, which is a more physical job. And at the end, from the total population, 85% of patients at baseline describe their performance at work as satisfactory, versus the 15% who already at baseline said that their performance was not satisfactory. So it was a regular cohort of patients with rheumatoid arthritis, we could say.
Okay, well, that's helpful, and I think it's always important to understand how things generalize. And so, very useful, and thank you for answering that. So now let's talk about the key findings. What did you learn from this study that you can kind of share with the audience here briefly today?
So the main finding of our study was, of course, the thresholds we calculate. The thresholds we calculate for example, for the WPA equal or more than 40. We can remember that this is a scale from 0 to 100, where 100 was is higher presenteeism, so worse outcome. In the case of the QQ method, less than 7. QQ method is a scale from 0 to 10, and this is the opposite way around. Is 10 the best quality? So if we had a patient with a QQ method less than 7, it will mean that the patient is not satisfactory with their work performance. Then for the Walls questionnaire, which again is a scale from 0 to 3. 3 is the worst outcome. The threshold was equal or more than 0.75. And for the WLQ 25 score questionnaire, again, from 0 to 100, 100, more limitation. Score equal or more than 29 was the threshold we choose. Then another interesting finding was that our clinical outcome, in this case, pain assessment equal or more than 4, can also be used to accurately identify those patients with an acceptable work state. Another interesting finding is that apparently the presenteeism questionnaire that performs better is the WPA, with a good prediction, which had a good performance to identify patients with an acceptable work state, but also to predict adverse work outcome. And then one of the most important points is that the same thresholds can be used in patients with rheumatoid arthritis, but also in axial spondyloarthritis.
A lot of interesting findings there. Maybe, taking a couple questions about each one. One thing is, of course, and maybe this is getting to the next question. So, but in terms of implications, but just to make an observation, I have some interest in pain, and a lot of people have done different ways of looking at what is the level which begins to be unacceptable and perhaps to interfere with activities. And I'm familiar with a paper by Yvonne Lee's group at Northwestern, published in the last couple of years, that looked at the level at which pain becomes interfering in activities. And I think it was around 3. So, similar measure as you came to, actually, with the number 4. And probably there are other studies along those same lines. So that consistency is, of course, good to see maybe in the literature.
Yes. And of course,
yeah.
It would have been interesting to assess with disease activity, but unfortunately, this score did not have any disease activity score. So that was the clinical measure we could use.
Yes, absolutely. Well, I think maybe getting into the implications of the findings, maybe you can tell us about what you have learned from this study in terms of your next steps for either further research or how you would think about moving this into the practice. If you could speak to the fact that actually you've got several questionnaires there, and I'm wondering which ones you would implement or take forward, since it may not be practical to ask four questionnaires, or how you're approaching that with your work going forward.
I will take this one, John. Thank you very much. Yes, definitely very good question. although it was not our objective to assess which is the best performing instrument, that would need another methodology. But the WIPI, presenteeism, is the most commonly used instrument. And in our study, it actually performed the best in identifying patients who may benefit from a tailored care. So answering your last question, which of the four would we bring forward? Then we would select the WIPI, which is more widely used and has performed the best. And what are the implications of this study? Well, work outcomes are not always consistently collected in our daily clinical practice, but they are important and they have a huge impact on patients' daily lives. Maybe with now with times in which we can make use of patient reported outcomes that can be collected in advance through the electronic medical records, and we can receive responses from patients ahead of the consultation. A WIPI questionnaire could be a very simple way to be informed about the work status of patients. And to with these cutoffs, we could very easily signal patients that may need some more tailored care. Also because there's literature showing that higher levels of presenteeism are associated or lead to withdrawal from workforce. So either sick leave or work disability permanently. So if we can identify these patients earlier down the road, then we can know who are the patients that eventually can benefit from tailored treatment and maybe tailored care. And I'm already responding to your next question, which is how can we bring this forward? What could we do? That's one possibility, by identifying those patients that required more tailored care, whether interventions are efficacious on them. And on the other hand, as Dafne mentioned in the beginning, although this analysis or the outcome of this paper is not meant per se as an outcome of a trial, having cutoffs for the WIPI also allows to analyze trials with this outcome or of being or not in an acceptable work state, or whether and if patients are on it or leave it or lose that acceptable state or get it that acceptable state that they did not get before. That's also a possibility of looking into the data in that perspective.
Thank you. That's very insightful, and I think that gets at the critical questions of how to use this in practice and how to get to that state going forward. A question now about, you mentioned earlier about your interest in seeing how this would apply and actually about how the thresholds were similar or nearly the same for the axial spondyloarthritis population as for RA. I guess tell me more and talk more about the interpretation of that. Did you expect to see that? And maybe what does that mean for using these questionnaires and studying them going forward?
Well, we did not know exactly what we would get, so we took the risk of developing from scratch the best performing thresholds independently in each disease. But in the second one we conducted, so in the RA study, we also wanted to test the thresholds that had been developed for AxSpA. Fortunately, they performed the best, especially with the WIPI and also in RA. That's very reassuring, and that makes it the implementability of this much higher, because as we mentioned in the beginning, you were saying if we start having different thresholds for different diseases, it becomes much more difficult to use them. So we are happy with the finding, and I think it facilitates implementation.
Yeah, for the is it WPI, right? So how many questions are in that instrument? Just out of curiosity.
There are actually 6
5 questions.
You go.
Go ahead.
No. You go.
There are actually 6 questions that there is that with those questions we can calculate different things. We can calculate the score for presenteeism. There is no specific question for presenteeism, but with those questions we can calculate presenteeism or absenteeism, for example, and then we have of course the result of the individual questions. But for presenteeism, we need to use 2 of those questions to calculate the score.
Okay. Well, I guess I was just thinking, I don't know about you all, but when we try to build in more questionnaires into our electronic health record, some of the IT personnel, of course, complain because they have, when they have to build in additional disease-specific measures, I guess it can add burden to the patients. But it's nice when questionnaires are not that long. It's only six items is not very much and would not take patients very long, I'm sure, to do. So that's good. Maybe my one additional question I just thought of is considering the correlation with pain. A lot of us have pain measures implemented in our EHRs already. I don't know what you all use. We happen to have the Promise, if you're familiar with the NIH developed Promise measures. And we track, of course, just a numeric grading scale on pain as well as promise pain interference. I'm wondering if you've thought about correlating some of the measures that you've used in your study with other types of, I guess, more generic pain measures, and whether or not a measure can be identified or a threshold using such a pain, especially a pain interference survey that might correlate with that value.
We didn't had them, but we also found it from the start. We had the same question as you. We can only ask a limited number of questions to patients to prepare their visit. We didn't have the promise function or the promise pain or fatigue questionnaires, but I think it is valuable to look at it. We must admit that the WPAY had an area under the curve almost 0.80, which makes it a good measure to be used in clinical practice. And in general, I think that difficulties to perform your work has some other aspects related to work-home balance, to specificities at work. So I think it is still valuable to ask specifically about your work. But if your functional ability or your disease activity or your pain is higher, then that question is more relevant than when you are in remission and have no residual symptoms. But we didn't look at that, but it's very definitely interesting to explore that further.
Well, I think your answer was right on point and actually certainly provides justification for your approach. Of course, the unacceptable kind of work state, probably has many dimensions, and pain being an important one, but there are other aspects to that, as you highlighted very well just now. Of course, pain affects fatigue or excuse me, the disease can affect fatigue and sleep and ability to communicate and cognitive function, many other aspects as well, that would have an impact. So I think it using a specific measure in many ways would be ideal if possible. So it's great that you've done this study. I really appreciated that. What other any things that we've missed that you feel is important for the audience to understand about the work that you presented today?
Not really. I like the idea that you agree with us that we should not only treat to target, but also try to target at work, because keeping at work is quite important for our patients. It's financially important. It's also beneficial for your mental and physical health. So I think that's also part of the message that we want to give target at work. And the availability of a simple question makes it much easier to ask how are you doing at work? Do you need any help? Can we support you to stay healthy and sustainable at work?
Well, those are wonderful pearls, Annelies, and I think that the concept of bringing in the unacceptable work state as a target for us in practice, and a way for us to be discussing openly with patients how they're doing and how we can support them more. Maybe those are some very important takeaways for everyone reading your article and attending to this session today. Well, it's been lovely chatting with all four of you. All three of you, and thank you so much for joining us on the Journal of Rheumatology. It's been, great to discuss your paper's findings and implications for patient care. I want to say to our audience, please read the article, Unacceptable Work State in Rheumatoid Arthritis, Establishment of Thresholds for Presenteeism and Clinical Measurement Instruments, that is now available on our website, jrheum.org, and in the May print edition. Thank you for joining us. Stay tuned for next month's interview with another featured author from the June 2025 edition. And please share your comments on X @jrheum or email at manuscripts@jrheum.com. Have a great day.